Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Maulik Purohit. Dr. Purohit is a physician leader, digital health executive, and clinical informaticist with more than 15 years of experience leading large healthcare IT initiatives with tangible results by leveraging healthcare IT, product development, and digital strategies. He's currently with Lehigh Valley Health Network, where he serves as the Chief Health Information Officer. Dr. Purohit, Maulik, welcome to the show.
Thank you. Thanks for having me. It's always an honor to be here.
Well, it's absolutely amazing having you on the show today. You've had one of the most diverse and unique careers I've ever seen in healthcare, from internal medicine and integrative medicine with a focus on brain injury research to informatics and leadership. And so I'm really curious to start the conversation. What drove your interest into healthcare in the first place?
Oh, thanks. Great question. So ever since I was a kid, actually, my first option was to be a pitcher for the New York Mets. That ended quite early. And so then my backup was to be in healthcare. I don't know what prompted me wanting to be a physician. As long as I can remember, I wanted to be a physician ever since I was elementary school. And just something about it really appealed to me, being involved in the care of somebody else. That all seemed like something really cool way to live life, right? To care for somebody else and really give what you can to make that person's life better. That always appealed to me. I don't have a good reason as to why, but sometimes we just, are attracted to something, and that's what it is. What I'll say is that it became more formal for me when I was in high school. And, I'd always talked to my parents about wanting to be in medicine. And so when I got my license at 16, and my grandparents were close to us. So my mom's like, well, you want to be a doctor? Your grandparents got to go to the doctor. You get a license and go. And so I ended up being involved in particularly my grandfather's care for obvious reasons, in terms of a lot of his appointments and everything. One of the reasons because I could translate. And they spoke Gujarati, and so Gujarati in English. And so I was a translator and helper and chauffeur and Uber driver all in one. And when you're 16 and you have to do that, your initial thought, oh, why? I'd rather be my friends, do this, that, right? But through that experience, and probably I might choke up a little bit because it's a little bit emotional, but I really became a lot closer to my grandparents, and then my granddad especially. He told me a lot of stories that as we're doing the rides together, and I learned a lot from him. And I didn't appreciate how special the moments were until much later. As we went to the appointments, I learned what he was really struggling, what it meant to have, medicine, like we talked about getting older and having large prostate and BPH. And, in medicine, it's not minor conditioning to this, but, talking to him, being in the car and understanding his experience with it, like, man, this is actually pretty bothersome. Like, it's not we think it's a minor thing in healthcare, but minor from a healthcare perspective versus minor to the patient are two different things. And so I gained a much better appreciation for calling something minor in healthcare. And the other part was, as I was with him and I experienced seeing different doctors and nurses and et cetera, we were lucky we had a wonderful experience with the people that were helping us with nursing care, with physician care, et cetera. The thing that stood out, though, was the limitations of the system itself in terms of the quality of care that you can receive. And although the people are doing their best, we just noticed, and this is in the early 90s, and you don't really have a patient portal. You don't have, you have to call for lab, you call for results of x-rays, et cetera. And how difficult it was to be on the phone, call, get results, go back and travel and access. And he was also elderly. At a certain age, walking became difficult for him. And so you realize how the system of care could be a huge barrier for someone getting access to care. And some of that, unfortunately, is still true today, 2 decades later, 3 decades later, in some of those access issues. But to me, that made a huge impression because I wanted to not only be a physician, but also I wanted to help clean up that system of care and how to make it better for the patient so that anybody else having to go through that, the same level of difficulty to get care.
Wonderful. And Maulik, maybe not so surprising then that you've had a history of taking initiative and being fairly entrepreneurial and trying to bring change to the system and improve practice. One of the things that you're known for is establishing the inaugural concussion program at Mass General. What was the origin story behind that?
Well, when I started fellowship, it was part of the Harvard healthcare system, and I was a research fellow for brain injury. One of my mentors, I was lucky to have several really good ones. One of them is someone named Ross Stefan, who is the chair of Human Art Department, Physical Medicine and Rehab, which is my core specialty, and I subspecialized in brain injury. And in the first few months, one day he asked me, hey, do you want to help out with the confession program? And I think, as you know, when you're low on the totem pole and the chair of the department is asking you, do you want to help? There's really one answer, one right answer for the question. But I'll tell you, as much as I joke about it, I'm very grateful for him involving me in that whole process, because in that executive meeting of the planning committee, it was some of the most phenomenal physicians and others in that room, from pediatric chair and head of the pediatric program to neurosurgery to neurology to others. And I got to see some of the topmost leaders in healthcare on a regular basis for this meeting, discussing how we're going to plan this out. And I learned so much through that process. And I'm eternally grateful, because it really launched a lot of different things for me. And then through that process, as you know, the other part of this is, things typically roll downhill, not the other way. And so I ended up being a lot of the frontline work for this, in terms of thinking about the clinic and the practice, and how are we going to have patient flow? How are we going to hire people? How are we going to educate them? How are we going to create templates and that kind of stuff? At first, I showed up to the meeting, and one rule I learned is to show up and shut up in the first few weeks, right? Be seen but not heard. And so I listened a lot. And then eventually there was a moment for me to interject an idea, and I did. And then it worked, and people liked it, and they gave me more opening opportunity to speak. And eventually we got to the point, and we started talking about things like marketing and finance and business planning. And so I was very involved in a lot of those things. And it really helped me understand the business side of medicine, the consumer engagement side, the patient experience side, the quality metrics, in addition to just the clinical care things. And it really felt like running a startup company in a parent organization as the process through all of that. And so it was a great experience. I'm eternally grateful to Dr. Zafont for inviting me to be part of that. Obviously, there's a lot of hard work you have to do as a part of it, but that just goes part and parcel. You have to have a mentor that sponsors you, and then you have to make your own effort within that. And I was lucky to have that mentorship in that sense to be able to start it. And I'm also grateful to another mentor, Russ Phillips, who was the chief of division of medicine at Beth Israel at the time. And he also allowed the fellowship that I had, was actually a joint combination between Beth Israel and Mass General and Spalding, putting it all together. And so I'm really grateful to both of them for allowing that fellowship to happen, and then allowing this opportunity to happen. So it was a fantastic experience, and really appreciate everyone who put in the effort to make it happen.
You brought up something really interesting, the idea that as a physician, you had the opportunity to expand the scope of your responsibilities and knowledge beyond clinical to the business of medicine, quality, consumer experience, and all that. And it feels like, you're not alone there. It feels like a lot of physicians have to develop those skills and knowledge pieces now. But it also feels like it's really hard to somehow bring all that into clinical training on top of all the clinical things you have to learn. Do you feel like going forward, there is or should be room for the business of medicine and all those other things in clinical training, or do you feel like that's just something that you just have to now learn when you get into practice?
Yeah, I think that's a great question. I think the clinical aspect is still very heavy, right? To be proficient as a physician requires a lot of dedication, time, and effort. And it's not just 80 hours a week in a hospital, but reading, understanding, thinking about your patients, all the stuff that goes into being proficient at your profession, right? Whether you're a musician, whether you're a singer, whether you're an athlete, you know the level it takes to go from being average or good to being great. And that distance is pretty huge in terms of effort and time. And so to do that as a clinician is hard. You have to spend the time. The pressure of today is also, how do you do that and also learn all the other stuff? Because you really can't separate the business of medicine from the quality of care in today's world. Not because it's all about money, but understanding cost of care is important, because if you have a choice of, let's say, 2 medications in front of you and they're equally efficacious, then you should know the business of medicine and how to reduce costs and take the one that's less costly to the patient and to the health system, because that is important. So it's not that money drives things. Money does drive things in many ways, but knowing how to most efficiently use your resources to drive change is a business principle, is a clinical principle, is a quality principle. And so all of those things come together. And if you learn just one side of it, you won't be as successful as if you learn all of those things. It's a huge pressure because it's hard to learn everything. And if you imagine somebody who went to med school and then in residency and in a fellowship, you've gone through, a decade plus, a decade and a half of this process. And now you're in your early to mid 30s. And you also have if you want a family, if you want to spend time with the kids. So there's all of those pressures that add into this. And I think it's a really different world right now. And I'm grateful because I had really good family support, wife and 2 kids, and others, and parents and others that really supported that journey that allowed me to get to the level I was at. But if not for a good family support, it's hard to get there. And in today's world, it's a blessing to have that because it's not that easy. And that's one of the reasons we have some of the burnout issues we have, because nobody who's a physician wants to be average, right? None of us, none of us got into medical school because we're happy being average. But that drive to be great, it competes with the time demands of other things that are there.
That makes sense. So, Maulik, when you finished this fellowship, you could have gone in so many different directions at that point. You'd learned the business of medicine, you're a physician, eventually you made your way into informatics. So I'm really curious, what kind of drove you there at that point? Was there a defining moment for you, or how did that happen?
Yeah, good question. So I'll be honest, I never knew that there's a role of the CHIO or CMIO. Frankly, it didn't really exist when I was in medical school. And I never imagined myself when I was in school doing anything except seeing patients. That's what everybody at the physician did. And that's what I knew. And so I did the professional thing, all that, everything was going well. Was a researcher. And I also got a second degree there, MPH, to learn bioinformatics, data analytics, a lot of other stuff that came with it, study design, all that. Things I didn't expect to be helpful later in life, but have been immensely helpful in later in life. And so I did that. And I'm still at heart a researcher because I enjoy asking questions, learning, being curious, and then learning more. And after my time at Mass General and Spalding, I was recruited to be in the Department of Defense to help expand a growing program for brain injury and PTSD. And there's a lot of great people already there. I came into the system. My role is as Chief of Research and Chief Medical Officer at a relatively young age. And one of the things we did was we built a separate building, expanded the program, but that program grew from several thousand visits a year to 22,000 visits a year by the time I left, and became one of the largest by volume programs in the country for brain injury. And as we're doing this, the researcher means I want data on the patients because I'd love to use that data to understand, what's going on. We didn't really have a good understanding. We still don't in many ways of brain injury and why it happens, who gets it, why do some people have more symptoms than others, why do some people take longer to recover, what are some of the major risk factors? And we don't have a great understanding of that because we don't have large epidemiological studies. Cardiology, for example, took off because of the Framingham study that enrolled people and we really gained a huge understanding of cardiology and the risk factors and that kind of stuff. And really, the term risk factor came from that Framingham study. It didn't exist before. And so I wanted to do the same for brain injury. And no platform database existed to get into that. And so I went down the path of how do we create a platform and analytics and that kind of stuff to collect data on patients, understand them, see them in a longitudinal fashion, and then see what happens if you treat 100 patients with this or 100 patients with this, who gets better, faster, all that kind of stuff. The concepts of predictive analytics, the concepts of AI generation for that data set. And it's important for many reasons. And from a patient care standpoint, the Department of Defense in planning strategy, are we going to be able to count on this person to be on the front line or not in 6 months or 12 months? Those are really dramatic issues because we talk about sports and if you have a quarterback with a concussion, are they going to be able to play next to me? And sports is important, but I think without argument, it's probably a lot more important for the people who are defending the country to know whether they're going to have the people to defend the country or not, right? And those kind of things we couldn't predict. And so those are the kind of things that we want to help get there. And so we started going down the path of creating an analytics platform. I learned a lot about IT through that process that I didn't expect to know, like setting up a Wi-Fi network. I learned all the nuances of what a Wi-Fi network is, how to set it up, why it matters, why do you want A, B, C, or G, and all that, all the different things that go into it. Where do you want routers? Where do you want the points? Where do you want the wiring? And I learned because nobody else was around to get into it. when you raise your hand and you have an idea, sometimes you're the one that has to execute it. And so that's what happened. And so I learned a lot of stuff about that, because we needed the Wi-Fi to then have people have iPads and other things to then be able to fill out their questionnaires and all that stuff. So then, working with the government IT team to build some of the platform and the initiatives and the development of that. Along with that came the workflow, right? How do you, a patient come in? How do they sit down with the questionnaire? How do they know when to go, what questions to answer, that kind of stuff. And they're really working with a full team of people at Fort Belvoir to develop these processes and the outcomes of data collection. So then we can understand the pathology better, et cetera. And so the whole list of things. And that effectively was a lot of what informaticist or CMIO would do, is create the system of workflow, process, data analytics, and all that kind of stuff. And as much as I love research and being a primary researcher, I realized that the impact I could have through a role like the CMIO role would be much more impactful than the research I was doing. Not because it wasn't important, but the things I was looking at with integrated medicine was looking at the use of integrated medicine for brain injury and recovery. And at that point, it became pretty established that meditation, yoga, those kind of things are really good for your health. And they also have been really good for the brain. And then some of the other stuff, I was asking were more academic questions. I'm not going to tell patients not to do yoga or not to do meditation. We've already established they're really good for the brain and really for good health in any way. So then at that point, I realized my research was good, but to really have impact, work on the system of care, which really I thought, going back to my high school days with my grandparents, that really is an opportunity to make change and drive that through the next step. It's around that time that confluence factors happened, and I was able to shift into a formal CMIO role in Texas. And so it wasn't the process of I wanted to be CMIO and I thought about it and I worked towards it. It was more I was a researcher. I had a lot of curiosity. I wanted to solve questions and ask questions and get answers to them. And I wanted to make impact on the system of care. And the two came together and led to the CMIO role. But it was never the aspiration to be in the role as much as it was to functionally help healthcare get better.
I love this. I think, to that point, if someone focused so much on my goal was to become a CMIO or a CHIO, and once they got that opportunity, maybe they're not as motivated to make those improvements. But then because for you were motivated more by solving problems for the system. Now that you're, the CIO at Lehigh Valley, you're probably like, well, my life just started really. I'm here to solve problems. And I'm curious, so when you started in the past year at Lehigh Valley as a CHIO, what's the first thing that you do? Like, how do you decide what your first priorities are? It's kind of like almost like a blank slate for you in some ways, or maybe not. I'm kind of curious how you thought about it when you started.
Yeah, great question. Going back to that, the point you just made about the CHIO role. So the aspiration for me has always been, how do I make impact? And the CHIO role is one that's important because it gives you the platform to have decision-making and influence and authority to make decisions, which all contribute to that. But the role itself is not the goal. The goal is to help healthcare. And when I was interviewing for LVHN, the thing that struck me that really it still strikes me a lot today is that it's a very progressive organization. It wants to make changes. It wants to push the envelope. It's definitely not happy with the status quo. And it really wants to push ahead and be a leader in healthcare. From the CEO to the EVPs all the way down, including my direct boss, Mike Rossi, is there in a huge push to make healthcare better in all the ways that statement applies. And that was the really most attractive part of LVHN for me in becoming here. When I started, one of the things that I knew from some mentorship at UH from Peter Protovos, who's my boss at UH, was one of the things that we do in healthcare is we have a lot of waste. And how do we reduce that waste? So I knew of a product from my prior days that can help with that and decision support. The name of that company is actually Illumicare. And we'd had a lot of good success with them, and they've had success in many places in terms of reducing costs. And what they do is they look at the data for cost in real time and compare it to what a patient is currently using. And they give a nudge in real time to the clinician to say, hey, Dr. Jones, you've got patient on antibiotic A. Based on the lab values, looks like antibiotic B could work just as well. And it's half the price, whatever it may be. And would you like to change? Well, it's awesome. If I have that in real time as a clinician, that's awesome. That allowed me to make that decision. Up to that point, we've never had that data in real time, what exact costs were for my system at that moment. And not just the cost data, right? Because Epic does give you some semblance of cost data when you're ordering. But the difference here was, instead of putting all the steps of cognition onto the clinician, the software actually does that and gives you decision support. So, for example, it will go through, look at a culture result, identify what the patient's antibiotic needs are, identify the difference in cost, evaluate whether the patient's allergy or not, then take all that information, give you a knowledge, a very concise form that takes all those different factors into consideration and gives you a knowledge in real time to give a suggestion. And then it's up to the clinician whether the suggestion makes sense or not. They might say, well, I get it, but I really need an antibiotic. That's fine. That's clinician expertise, and they have to give that. But this at least automates some of the processes of searching for all the different bits and pieces of data and currently we're into one succinct nudge in one place that then the clinician can make a decision on. And it's really, the way I look at it is, a lot of these products should be like the GPS that we use when we drive, right? Most of us, and I think most of us know how to drive. If you ask my wife, she might disagree with me about my knowledge of driving, but we have a license or we're capable of driving. We might live in an area that we know the route and the direction we're going, and that's great. And so we might not need GPS, but the GPS offers real-time data that tells you where the traffic backups are, what some of the delays might be, if there's whatever it may be, right? And that gives you that real-time data as decision support on whether you want to follow that route or not. And you might still decide I want to go left instead of right. And that's up to you. That's your expertise as a driver and expertise in the area. But at least that decision support gives you a layer of data and knowledge that you wouldn't have had otherwise. And that's the way I look at these tools in healthcare right now is they should at the very least offer that level of support. On the non-clinical side, like operations or RepSec and those other places, I think you can really push the envelope a lot more with AI and automation and have them actually do the task and really eliminate the things that a human might do so that the human can do something at a higher level. Instead of doing manual tasks, entering or having the same thing over and over again, they can now do something else, which requires human, like thinking and processing and analysis, right? So now you can use the people on your team to do much better work and alleviate the boredom of menial work. And so there's a lot of places where I think AI can really do a lot of full automation. On the clinical side, I'm still cautious because I haven't seen a tool that can form a human in every situation. Now, we've seen certainly AI, and you get the news about ChatGPT performing better on tests and all that kind of stuff. Taking a test and seeing a patient are two different things. I mean, hands down. And so there's certainly room for decision support, but I'd be careful in completely eliminating clinical care from humans in lieu of an automation or AI tool, just simply because we're not fully there yet for a lot of reasons. And that's not to say we may not get there. I would love for some things to be automated, but I don't think today is that time yet. We may see that soon. I wouldn't doubt it if I saw that in my lifetime, but today I don't think it exists.
One thing that we've heard today, but also we've heard from past things you've said or written, is that you have a pretty, I think, healthy skepticism of AI, right? You obviously believe in its potential, but you also don't get on the hype train very easily. Kind of curious, what are the things in AI that you think are the most exciting for the next year or two? And is there anything that you feel like is actually overhyped lately when it comes to the AI conversation?
I'll tell you, I don't believe in AI fully because the day Netflix can tell me what movie I want and be right 100% of the time, I'll see it. And that will be there. But I think, joking aside, I think the reasons for having a skepticism of AI is not necessarily the skepticism of AI itself, but so much the back end of what AI relies on, which is the data itself. If the data is clean and pristine, without error, without inaccuracies, without integrity issues, without missing data, then I think AI will function much better. I don't think anybody would dispute that part of it. And until we get there with data, I think we're going to still see fallouts from AI in healthcare. And there are lots of reasons, but healthcare data is, I'm going to steal a quote from somebody that I heard speak one time, and that is that data in healthcare is like a book that you're reading that in multiple languages, sometimes left to right, sometimes right to left, upside down in some pages, right side up in others, some pieces torn, some pieces not torn, and in all random order, right? And that's really a lot of the case with healthcare data on the back end until you clean it up. And the cleanup takes a lot of time and effort, and that process is not perfect either. And so there's a lot of steps to get to for AI to be fully valid and useful. It's not to say it's not useful now, but to be fully automated and have no human in the middle, I think we're a little ways off for those reading the data. But I'll say the issue with data is more in the data capture side. Until we actually really fully build healthcare systems that truly understand user interface and human-centered design in the way we use them, we won't get to great data capture. Because as long as I have to click 10 times to do one thing, or the drop-down menu is accurate, whatever it may be, until we get to a point where those things are done well, we won't have great data capture. And those are some of the limitations. If you look at Google, for example, and you look at anything that you enter online for Google, the data capture makes pristine sense, like who you are, where you are. They really take unstructured data and convert the structured data in some magical way. They give you great output. I mean, it can predict my email long before BART existed. And that's just awesome that they can do that. And then it's also easy to use. Like if you have one Gmail address, that account and login gives you access to not only email, but also to search and map, to photos, to Drive, to Workspace, to YouTube, on and on and on, right? It's one clean, pristine logon that goes to the entire ecosystem, and it's very easy. You don't have that user experience in healthcare at the same level. And I can name Google, I can name Amazon, I can name Apple, you can name it, right? I don't need to isolate anyone personally, but that experience of consumer experience for those Silicon Valley products far exceeds the majority of the healthcare products that we have. And it's not just a product itself. Like Epic, I think, did a really good job with the EMR. I don't put the blame on Epic. I really put it on the way we regulate healthcare and all the different things that go into it. If you have an MA at a outpatient clinic that's freestanding versus a hospital clinic that's versus a clinic that's within the four walls of the hospital, the rules are completely different. And so then that means that your technical build is very different. And you're going to account for so many of those that build becomes so complex that it becomes cumbersome for the user. Until we get to a really clean way of doing healthcare, in terms of regulations and all the processes and operations, we're going to have these limitations in the user interface. So it's not a limitation of the product and the company as much as it is our ways of using the products and our input into the design of the system itself, which needs a lot of work.
Yeah, makes sense. So Maulik, you had a great analogy about the AI and using the GPS. You're going to make the executive decision to turn left as opposed to right, even though data might tell you otherwise. You shared your thoughts on this topic in the past, but I wanted to dig a little bit deeper around AI and critical thinking. So really it's a function of AI combined with critical thinking that gives you that great result that you're after in the long run. Some clinical leaders that we've talked with in the past have talked about their concerns around automation complacency. The idea that, we might trust AI so much that we're not even looking into the various inputs that brought us to the output, which could obviously lead to harm. How have you thought about automation complacency, and what are you doing to maybe circumvent some of the concerns with physicians?
Yeah, that's a great question. I think I used this example in another podcast. That was that when I'm at Nest at home, I have a Nest thermometer, and I get into this automation complacency with the temperature side. And so I go to town, and my wife called me. He's like, "Why the hell is it so cold? Why is it so hot?" And I'm like, "Oh shoot, sorry. I guess actually the process is better." And that happens to us right now. A temperature setting that's inaccurate, really not much damage there, right? But you do that in healthcare, you can really cost them, no doubt. So you have to have guardrails around what you're doing. You have to put in a structure that forces people to not be complacent, because the inherent human quality is that we become complacent because it allows our brains to work on autopilot, so we can focus on things that require brain power higher, right? It's just, whether we believe in evolution or not, just the feature of how our brains function. And the idea is that if we are in a place where there's danger and safe, we're not going to focus on what's safe because we know that's safe and we don't need to worry about it. We're going to focus our brain attention on things that change, because that change could potentially be dangerous to us. Yeah. And so our brains and eyes and entire senses are geared towards detecting change. And so once you get into a rhythm, it is humanly impossible to not be complacent about something. Now we do this when we're driving, right? If we're driving the same route from work to home, and you've done it 1,000 times, you feel like you can do it in your sleep, and you stop focusing on the road. So that one day it's on the onset, and you're like, don't get in my lane. And you're like, oh, shoot, I should pay attention, right? That change prompted us to jar us out of our complacency because that horn, so, there's something dangerous, something we should pay attention to. But outside of that horn, we'd be on all right. That's done by design because you need energy conservation. If your brain is fully attentive to everything in the environment, you would wear yourself out in like 1 hour of being awake. There's just no way that human will possibly do that. So that's the way the brain functions, is to turn things into autopilot, less energy use, so that you can focus on other things that do require attention and focus. So it's humanly impossible to do the things that don't become complacent if things are working well. So what do? Then and I know that part of my brain injury background and stuff coming into this, but that's where the clinical background sort of influences my other parts of what I do. But I think the other part of this then is, how do you build a structure so that complacency doesn't become dangerous? You have alerts, you have things. And so every situation is different, but you have to build in structurally into the technical build to allow complacency to not happen at the most critical junctures. And that's the only way to ensure safety. If you rely on human process in education and in a workflow, you will fail and you will have an event. Not because the person doesn't care, not because we're not focused, not because we're not caring, but it is the way the human brain or mind is structured that when things are automatic and working well, we take our focus off of it so we can put our focus on other things. So that requires us to build things from a digital perspective that overcomes that inherent limitation that we have.
That makes some sense. I mean, I think to your point, using your example of the GPS or not GPS, sorry, let's say autonomous vehicles for driving, if it does get to the point where it's incredibly safe, the error rate is very, very low, you can tolerate a lot of human complacency. You don't need to be watching the wheel the whole time that the autonomous, software is driving. But I think to your point, for clinical medicine, you still have to identify what are those critical junctures where you have to have your hands on the wheel. It sounds like that makes a lot of sense. One of the things people worry about with AI is, how do you actually leverage it in clinical care without losing the human aspect of it? So maybe a good example would be, more and more folks are trying generative AI to help draft responses to patient messages through something like MyChart. And some people say, well, you could use prompts to send more empathetic, messages, for example. I'm kind of curious, what are things you think we can do or we should keep in mind to make sure that we don't lose empathy when we're using AI in clinical care or communication?
Yeah, great question. And it's a real struggle. I don't have a fantastic answer for this, but I'll describe the situation, at least so people understand, so just past the UTM, Epic actually presented on stage, Suthan Bell and Sumit Rana, the CEO of Microsoft. So Rana is very high benefit. And they discussed the use of Microsoft's new product like Copilot and other things, to put that and infuse that into Epic and other products to automate some things. And just for awareness, GPT is owned by a company called OpenAI, and that company is bought by Microsoft. So now it's all part of one company with Microsoft. And the thought is, ChatGPT can really do human-like functions such as respond, etc. Why don't we just put that patient portal message with MyChart into that, when ChatGPT can do the automated response? And that sounds great in theory, but it's not fully there yet for a couple reasons. One is, if a patient is asking a very simple question like, what time is the clinic open? That's easy, right? That's a very automated thing that doesn't change. You can just have an automated response from ChatGPT and say, hey, here's all the clinic times, time you to respond to that automated response, no big deal. That's fine. Or if it says, hey, I need to refill my prescription. Oh, that's okay. That's so, you can automate that to some degree. ChatGPT can say, hey, we got it. We're on top of it. Send a message to someone at the clinic to take care of it, and boom. Even that can be automated, right? But what if it's hey, Dr. Jones, I started the medication given yesterday. I'm having some side effects. I don't like the medication or other things, right? That's a really complex question. It requires not just injection of knowledge from the outside that ChatGPT does so well, but also of the patient's chart, right? And so looking at the chart and saying what medication are they on, other things are they on, what's going on in their life, what are they allergic to? Like, there's a lot of things that you think about. And all of that complex, not just data entry and information, but then converting that information to analytical thinking, insight, and knowledge that then converts back to what response they give a patient. I don't think any product is out there that can do that to that level. And there's a real danger if you give a quick answer or something else, right? Like, and I'm not thinking ChatGPT, but let's say any product or ChatGPT, whatever you name it, right? Any of these products in that same category. If you give a question, could this be causing this? Well, what the data they can ingest that's out there on the internet could be, you have medications, you have side effects, you have patient characteristics even, but all of that combined may not give you the right answer without the ability to analyze the patient's whole profile of what else is going on. And that's where the danger inherent limitations are. That's not to say that ChatGPT can't be great support, right? Maybe you type a couple words that give a prompt, and then that ChatGPT will populate the rest of the message. And so you reduce the time of answering the message from, say, 3 minutes to 30 seconds, right? But you've got a human supervising that process. They're just not physically typing something out. That's certainly a use case that can be done very soon. And so there's a lot of different ways to think about technology, to use technology. And we just have to be very careful that we put people up front and rather than think about consequences on what can happen and really be careful about how we use them. It's not to say, again, that we can't get there in a year or 2 years, whatever the time frame may be. But today, if you ask me, can we just turn on ChatGPT and have that answer my in-basket messages in Epic? I wouldn't automate that process just because there's so much unknown in that process. Now, can I turn on ChatGPT to give a response to basic straight up information like clinic hours or, does Dr. Jones have an appointment schedule available, whatever, right? Yeah, those things, I think there's less danger in that, first of all. And second, those are typically more pure information questions, not analytical thinking type questions. And so I think those are easy.
Maulik, I've heard on another podcast you were talking about books that you were into around leadership and culture. What are some of the biggest lessons that you've learned around leadership and culture that you try to impart most to your teams?
Oh man, I've had to learn a lot that started from a remedial standpoint. At the end of the day, what I've learned from a lot of different sources, leadership is really about caring what the people around. The concept of starting leadership, which really came in scripture from several thousands. I'm looking back in the way I remember reading that as a kid in my Sunday school Gita class, and they're talking about it. At that time when I was like in elementary school, I was like, oh, whatever, I don't care. I just want to go play basketball. But I'm like remembering all that stuff. It comes back to you. So I think there's a lot of cool stuff in a lot of the historical stuff that we have. And again, any religion anywhere probably has similar items. For me, it was from my background. But I think leadership, to me, that really just means care about the people around you. When they're going through something, ask them. When someone on the team's not performing well, my first question isn't like, what's wrong with them? In a demeaning manner, my question is, hey, what's going on? Like, are they having something going on at home? Are they struggling something? Are they, let's figure out, like, my response is to be curious and say, hey, what's going on? Let me find out more. And then getting into other things from there. And most of the time, people do have things going on with them. And there is something to be concerned about. Then help them out, right? Be part of the team, like help them out. But you won't learn that the person what's going on if you just pick them as an employee and say you're a worker and I need you to produce work product. If you don't produce work product, then I'm going to be upset. That's not the right place to be.
Yeah.
I don't know. That's not a place I want to be in, and I don't want any of my team to feel that way. I want them to feel open and honest and come forward. Hey, I'm struggling with this. Can I get them up? Yeah, absolutely. I think the other thing was about habits. I'm reading this book. There's a gift to us from a friend. The book is called Atomic Habits.
Mm-hmm.
You guys probably heard about it. It's the New York Times bestseller. But it's amazing, and it's a concept that makes so much sense, but none of us really have the patience to actually do it, which is, let me focus on 1% change today, and let me focus on 1% change tomorrow. Forget this dramatic, losing weight in 30 days or, gaining 20 pounds of muscle in 2 weeks, whatever, right? Like, we see all that. Or learning how to play violin in a month, right? Like, we get all these things, and our current products as a kid, like, you'll learn to speak this language fluently in 30 days.
Wow.
There's like, but I think if you make 1% improvement every day, the exponential improvement, and we talk about compound interest, but really compound interest with habits. And I'm reading it out with my kids right now in the evenings, and it's amazing. It's not just I feel like I'm reading it for them. I feel like I'm reading it for me, really, because I'm learning way more than I think they are. And just amazing some of the changes that happen with incremental change on a daily basis. A change that you may not even notice on that day, but leads to dramatic change. I mean, the story in there about the British cycling team, I'm sure you guys have heard of that story, right?
I don't recall it.
Well, so they got a new performance director in the early 2000s. And up to that point, Great Britain had not won anything cycling-wise for over 110 years. To the point that some of the major leading bicycle manufacturers will not sell bicycles to the British team because they were performing so badly. And they don't want to be associated with that team. And it's just amazing to that level. But then they had a performance director that only focused on 1% change daily. So they focused on things that, like, why would they focus on them? But they had a surgeon come in to show the team how to wash hands. Why would you need a surgeon to teach you how to wash hands? Like, well, if you wash your hands properly, there's less chance of you getting sick or passing germs. Well, that makes sense. So if you have fewer sick days and you're an athlete, that's huge, right? Mm-hmm. They painted the walls white. Why? So they can pick up and speck at dust much quicker so that people don't get bad stuff in the air and don't get sick. They talk about making the seat more comfortable so that they can ride for longer periods of time. They looked at making the clothes that they wore while biking more aerodynamic and sleeker and lighter weight, right? If it's lighter weight, less energy just wearing the clothes that you have. So things like that. And then also on a daily basis, they did a bunch of other things. And in the next 10 years, 2017, they won like 70% of all world medals during that time in the world for a cycling event. And they won in a 6-year period, they won 5 out of 6 Tour de France events. And so just amazing that they made 1% change and you didn't see the impact of that right away. You saw it took a few years, but then for the next 10 years, they dominated the sport like no other in the world, right? Probably the Patriots, I'd throw that one in there. The Patriots of the 20 years, right? 6 Super Bowls, 9 appearances in Super Bowl. So like those are dominant things that happen with 1% change daily. And again, it's hard to fathom that because on a daily basis, you're like, I didn't really do anything. But if you can stay disciplined and focus on 1% change, then that will drive so much change. And again, it's things that concepts that we probably know, but reading the stories about it, I think inspired you to do that on a regular basis. I've been trying to focus on that. I'll tell you for myself, today my 1% was to drink 8 glasses of water. That's it. That was the only thing I wanted to really achieve a 1% improvement. I haven't gotten there yet. I'm 75% of the way there. but I think but those things add up. And if you accumulate those things, I think they make a dramatic change on so many things. And we can apply that to anything.
No, I love it. So Maulik, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. Basically just 5 rapid fire questions. Sure. The first one you may have already answered, but we're curious, what's your favorite book or book you've gifted the most?
Well, right now, I think there's a lot of books I've loved. There's one that I read as a kid, which is Profiles in Courage by JFK, which is courageous action by people and founders and other people over the history of time. Amazing. It was a Pulitzer Prize-winning book, but really fantastic book and really about courage. Thirdly, Atomic Habits is awesome. I love it. Reading a lot. It's really helpful. So I'd say for right now, I'd pick those two.
Love it.
Yeah. Question 2, who is a person either dead or alive you'd love to meet?
Oh, wow. Dead or alive? Oh, it's a tough one. No, I'll tell you, I guess I could pick from any, but I guess in the lightning round, my son actually last year did a History Day project. It was Frontiers in History. People had really done something completely new in history that changed how things were done. And he actually talked about the nonviolent movement, nonviolent resistance. And he talked about Mahatma Gandhi and his life and how that contributed to that. So it'd be awesome to meet him and learn from him.
Mm-hmm. Yeah, I love that. Question 3 is a bit different. Would you rather have super strength, super speed, or the ability to read people's minds?
Can't have all 3, huh?
Yeah.
I should take the third one.
Would you? Yeah. That mind reading. I love it. Question 4, what is something in healthcare you believe that others might find insane?
Wow. I would say if we really look at the incentives of healthcare and how that drives behavior, that would be insane to most people.
Mm-hmm. Yeah, I agree with that one. Last question that we have, Maulik, if you could travel back in time to any event or moment, when would it be and why?
Even before like my lifetime?
Anytime.
Oh, wow. As Einstein was coming up with the theory of relativity, would be kind of fun to look at that. I was going to say, go back in time to see the first man on the moon. The problem, actually, this is the nerd in me, but back then there's no good TV. You couldn't really get like TV. So, well, that's why. But otherwise, I would pick man on the moon. Like if I could have like today's photography of that snap, I would take that. But if not,
yeah, that's awesome. Well, thank you, Maulik. That's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and want to learn more, visit www.seamless.md. Maulik, Dr. Purohit, again, thank you so much for sharing your wisdom with our audience today. It was an absolute pleasure having you on the show.
Well, I think that was a lot of fun. Thanks for having me.